So as far as the documentation is you know, I could spend days talking about wound care. I really enjoy this field. The wounds we see arterial and venous ulcers, we see diabetic foot ulcers, we see pressure ulcers, we see traumatic wounds, we see post-surgical wounds. As I mentioned before, we see burns that aren't significant enough to require a specialized burn center. But no matter what kind of wound we see, it all starts with the assessment. And you guys as nurses, just like our nurses associated with our wound centers, you're our first line. When we have patients that come in as an outpatient, our first interaction with the patient is with our nurse. She goes in and they perform a very formal history and physical with the patient, get all their meds listed and so forth. But then the next big thing as far as objective is wound documentation. And that's what I want to start with you. So to be consistent, and like I said, we have several sites. We have downtown, we have one, your neighbors over here on Broadcasting Road. We have our inpatient, but we're all under this one umbrella, even though we have these multiple sites. And it's the same for us, which I would think would be for you guys too. In other words, we have to be consistent among ourselves, because if I go out and measure a wound one way, and then Lori comes out and measures it a different way, it's going to create a whole different picture for yet maybe a third person that comes into the situation. So you got to have a general guideline and balance on how you go about this. And for us, we kind of go by what pretty much is in the literature as standard of care, and that is everything's in centimeters, obviously. We do length times width times depth, and we do it horizontally. Now, some documentation systems and some electronic medical records and so forth list things vertically, but we tend to do things horizontally. So when you see those home health papers that we fax, and I just talked to our nurses before I came over here to make sure I was on the same wavelength. We try to get those orders out to you guys the day we see the patient. So we try to get those orders faxed to your center here the day we see them. And when those orders are coming, we have 4 physicians we work with at our center. Dr. Malik and Dr. Thomas are both general surgeons. Dr. June is a plastic surgeon, and Dr. Guerin is a podiatrist. So those are our 4 physicians that we intimately work with at the wound center. Certainly there's other physicians not only at our hospital but at Reading Hospital and the surrounding area. So really any physician can send us patients and we'll take care of whoever gets referred to us. Most of the time the PCPs and so forth defer the treatments to our wound physicians, but anyone can refer to us. But getting back to documentation, so what you're going to find on those forms is we will give you a descriptor of exactly where the wound is, okay? And then we were going to measure, like I said, in length times width times depth, and those are going to be in centimeters. Now, when you're talking about descriptors, this is really critical in today's world, especially for third-party payers, because I also work on the other end of things, and I help our billing people with the edits we get sometimes when bills don't drop, and a lot of times it's little nitpicky stuff. So just to give you some pointers there to help you guys so you don't get claims decline or so forth. It's not enough to say anymore, patient's right arm was dressed with, ABC. I kind of just put some basics down on that little outline I handed out for you, but it really is important not only have right and left, but proximal, distal, anterior, posterior, superior, inferior, what do all these terms mean? Shoulder to elbow is arm, okay? Elbow to wrist is forearm, okay? Of course, your hand, you have palmar and dorsal, okay? With the leg, at the hip to the knee is the thigh, from the knee to the ankle is the leg, and then of course from the ankle distally is the foot. Dorsal foot, plantar foot, okay? Medial foot, lateral foot. Those descriptors are very, very important because a a lot of times we're dealing with patients that have multiple wounds. So we have to be very specific, because if our doctors come in and they debride a wound, they might debride several wounds, and in order for them to get paid, because the depth of debridement for this wound might be different from that wound, and if you don't document that specific, okay, it'll get, declined, it'll get refused, and so you want to make sure you're getting reimbursed for the work you're doing. So when your folks are out there in the field, it's that critical. Sometimes you run into, I can tell you, with all the experience I have, the foot is still challenging, because depending on where that wound is on the foot, I might say length is this way, heel to toe. Lori might think of it as dorsal to plantar. Well, you know what? Both are right, okay? Because all you have to do is designate what your reference points are. So a lot of times if I have one of those wounds that's kind of like in between, and I want to make sure, like, well, this is how I'm measuring it, how am I going to make sure the next person is measuring just like me? I'll literally write, right medial first med head, length 2.8 centimeters, measured dorsal to plantar. I mean, I literally will write that on my documentation. Times, width, 3.5 centimeters, measured heel to toe, okay? I'll write those little key notes right on my documentation, so that the next time someone comes along and it's someone different from me, there's no question how that was measured. Unless you can have a mind's eye of what I'm saying, it might not sound like how could that be confusing, but when you see these wounds at certain landmarks on the body, sometimes it does get a little confusing. The sacrum, know your basic anatomy. So we have the cervical, the thoracic, the lumbar, sacrum, coccyx, and the natal cleft. Okay, know those landmarks and word them appropriate. Left and right buttock. When you're dealing with these pressure ulcers that you're probably going to see out there in the field, it's critical that, especially if it's on the buttock area, make sure it's left buttock, right buttock. If it's more in the central, again, natal cleft or central buttock area, sacrum, left or right, paraspinal or right on the spine. All those verbal descriptors are important. So you're measuring, usually 12 to 6 and 3 to 9 for length and width, wherever the wound is on the body. Your depth is your straight in depth at your deepest point, okay? You want to make sure you get the deepest point, because the center of that wound may not be the deepest, okay? So you want to make sure you measure the deepest point. Usually then I get a measurement on my sterile Q-tip, and I'll just put it right up against my measuring device to get my depth, okay? Now, tunneling versus undermining versus tracks, okay? I can bring in 10 different articles right now for you guys, and I guarantee you all 10 will say things differently. And so it's no wonder our clinicians are out there in the field scratching their head like, is this a tunnel? Is this a track? Is this under? But for our sake, at least the way we're describing it, so your undermine is, picture you have this round wound, let's say. Okay, so here's our wound, and around the edge of the wound, I can get up underneath that Q-tip, and I have an end point, but I can get up underneath it. In other words, there's like a lip, if you will, underneath the wound. That's undermining. And the way we describe it is the face of the clock. So if this is my wound and it's on my sacrum, remember 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. So here's my sacrum, 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. So if I have undermining and I go up underneath my Q-tip, I'm going to say, okay, it goes from there to... So the patient has undermining from 12 o'clock to 2 o'clock. And again, I measure the biggest part, and that's what I did. And then I go on my little ruler and document undermining, okay? Now track and tunnels, I can tell you, are used interchangeably, but technically they are different. And the easiest way I can tell you, since we have some folks that like to visit people out in the western part of the state, if you ever go to Pittsburgh, you have to go through a lot of tunnels. out there on the turnpike. So remember that tunnels, you go in and you come out, okay? So if I have a wound and here's my wound, and I can take my Q-tip and I can go in this wound and oh, I can see my Q-tip on this wound, okay? That is a tunnel. There's two open areas that I'm just kind of going under the skin in this tunnel, okay? Just like on the turnpike. Win one side, come out the other. Tracks, there's an end point, okay? So a track, you go in, and doink, 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 you have an end point, okay? So there's your track, okay? But again, it's described by the face of the clock. So if we go back to my little tape measure, here is my sacral ulcer, if you will. 12, 6, 3, 9, okay. At 2 o'clock, oh, this goes in. Okay, so there's my track at 2 o'clock. I measure that. I do my length, my width, my depth. Track noted at 2 o'clock, measuring 6 centimeters, whatever the case may be, okay. Now, you have a case where you have two wounds, and we see these sometimes, okay? We had a patient that had a wound on the right buttocks, and then they had a wound kind of on the right ischium, okay? And of course, there was a tunnel in there, so we did length, width, depth for both wounds individually, and then I said there is a tunnel on the right ischial wound at 2 o'clock, measuring whatever. The right buttock wound had a tunnel at 7 o'clock, obviously the same distance, it's the same distance. But, so that's how we kind of measure that, okay? So tunnel, tracks, and undermining. So again, don't let yourselves get all crazy with this because the literature is more confusing than anything. Like I said, you can pick up 10 different wound care articles on documentation and you'll read 10 different things. And I guarantee the literature uses tracking and tunneling interchangeably. But again, if you want to be specific about it, tunnels technically have an opening on each end. A track has a definite end point, okay? So that's, and of course undermining is just that. It's like a lip underneath the wound itself, okay? And again, they're all measured by the face of the clock. Okay, so on our sheets, again, when you get these facts, we'll have the wound described, exactly where it's located, length times width times depth. There's going to be colors associated, okay? They're very important. Red, yellow, black, tan, white, epithelial tissue. Those descriptors are important because obviously you want a wound to have more red than yellow or black. Conversely, if you start out and you only have 5 or 10% red and 95% yellow or black, an easy way to know if you're heading in the right direction is over time, hopefully your red tissue is increasing and yellow, black, brown tissue is decreasing. So those descriptors are important. We usually go by percentages. So it's, you know, a certain percentage of red versus a certain percentage of yellow versus a certain percentage of black, yellow, tan, whatever the case may be. So those are also very important. The amount of drainage you have is important. So a lot of times it's either none, it's scant, min, mod, or copious or maximal amount of drainage. And that's important. So you're trying to paint literally a mental picture of what's going on with the patient's wound, because when you have the size and you're very specific about where it's located on the body, and you have red, yellow, black color percentages, and then you have how much drainage you have, all that information is very important so the clinician knows, what am I going to do? You know, how am I going to take care of this? What dressings am I going to use?